So this is my topic, translating epidemiology into action to eliminate disparities. I have a tendency to have a lot of slides, so I'm going to go through them quickly so that we can get to the end ones. This is an outline of the talk, basically. Talk about this movement to eliminate health disparities, because I think it really is a movement. Strategic plans in progress. Translating epidemiologic knowledge into public health action on disparities, and I'll give you two little case studies. Propositions about human behavior and challenges for epidemiology. But of course, it's not just epidemiology, but I'm an evangelist for epidemiology, so of course I'm going to say epidemiology. But anybody who studies population health is doing epidemiology, whether you're an epidemiologist or not. So health disparities has been a concern going back to the beginning of the last century at least. But a useful landmark for me is the 1985 report, the Secretary's Task Force on Black and Minority Health, report by Secretary Margaret Heckler, a committee that she established during the Reagan administration, and they came out with a statistic that minorities experience 60,000 excess deaths per year in the United States, and had 8 main recommendations in the categories that are there. Their introduction said, despite the unprecedented explosion in scientific knowledge and the phenomenal capacity of medicine to diagnose, treat, and cure disease, Blacks, Hispanics, Native Americans, and those of Asian Pacific Islander heritage have not benefited fully or equitably from the fruits of science or from those systems responsible for translating and using health sciences technology, which is a very uplifting statement, and we realize this is really important and something needs to be done about it. So something that helped change my consciousness was a 1991 annual meeting of the American College of Epidemiology. I was not involved in creating this conference. My friend Bill Jenkins and Ray Greenberg, who was the president then, Gladys Reynolds, and others planned it. But they chose the provocative title, or what was then a provocative title, because the word racism wasn't being used very much in scientific discourse. And one of the things they wanted to do was to bring it into the discussion. I'm skipping forward a fair amount, and some of the people who were involved in that conference were involved in shaping the goals for Healthy People. The Healthy People 2000 had various objectives for reducing health disparities, but they really worked so that by 2010 there was the goal of eliminating health disparities, which again was a big step beyond where people had gone before. Could you eliminate health disparities? There were still ideas that this is probably largely at least somewhat genetic, and so you're not going to be able to change things like that, and so on. So this was a major step forward in the movement to eliminate health disparities. Healthy People 2010, it wasn't one of 2 objectives. Now it's one of 4 objectives, 4 overarching goals. And health equity, the new terminology, is coming in there. And of course, health equity is much broader, really, than eliminating health disparities. So that's a very brief overview of the movement to eliminate health disparities. What about strategic plans? How has the government acted then on this 1985 report and the follow-ups to it? And of course, various professional societies have also had strategic plans and so on, like the American Heart Association, for example, and the Cancer Society and others, but I'm going to just focus on NIH. Over the last 2 decades, the overall health of the nation has improved significantly. Yet there continue to be striking disparities in the burden of illness and death experienced by African Americans, Hispanics, Native Americans, Alaska Natives, Asians, and Pacific Islanders. These disparities are believed to be the result of the complex interaction among biological factors, the environment, and specific health behaviors. Inequalities in income and education also appear to underlie many health disparities in the United States. So this was from the NIH strategic plan from the 1990s, I think it was. And this was a strong statement at the end because this is very different from the kind of discussion that had been going on before then, which was heavily biologically oriented. I mentioned the possibility of genetics. People talked about lifestyle exposures and healthcare access and things like that. But this brings in another dimension, which of course is a little harder for public health to do things about. And the strategic plan continued. In the fiscal year 2001, the NIH spent over $2 billion on research infrastructure, and public information, and community outreach efforts to reduce health disparities. This provided a strong basis for further investments over the longer term, investments that promise substantial progress in reducing the incidence, prevalence, severity, and social and economic burdens of diseases, and disabilities that affect racial and ethnic minorities and other health disparity populations. And you also didn't see the word eliminate in there. So then the next strategic plan, which came out several years later, medical and scientific advances have introduced new opportunities for the continued improvement of health for all Americans. However, in spite of notable improvements, I'm not going to read this one because you kind of know where it's going. In the fiscal year 2003, the NIH spent, I'm not going to read this one either, because the only thing different from the earlier one is the year has changed. And then in the most recent one, which ends this year, covers up to this year, it has a lot of good things in it, and I don't mean to make light of it, but its introduction or summary says, as long as even one of our fellow Americans encounters barriers to optimal care, whatever the reason, our work is unfinished. Well, care is only one aspect of what is an influence on health disparities. And of course, now we're not talking about health disparities for populations. This is one, if anybody. So now the mission is now enormous, and in the same way, it's sort of diffuse. So there are other parts of the plan that are more reminiscent of what we saw before, but it does seem to be that the movement is not manifesting in the same way. It's not progressing in the same way, certainly in NIH. And this is with an Institute of Health Disparities, Minority Health and Health Disparities. So they did Health and Human Services did a review in 2010 on the progress with respect to the various health objectives. And so I don't expect you to absorb all this. I have a little trouble absorbing it myself. But basically, this is a summary of the number of objectives where the disparity has decreased, or the disparity has increased, or there's been no change. And these are disparities by race, ethnicity, disparities by sex, disparities by education, income, geographic location, disability. The green ones are the places where the disparity has decreased. The red and brown ones are the ones where the disparity has increased. And then what you see is that most of the population-based objectives with data to measure disparities had no change in health disparities. So most of them don't change, and then they're the ones here that do change. And you can see that it's largely balanced, though for some of these areas it actually is going towards worse. And this is with the billions of dollars that are being spent and the statements and the commitments. So there are problems in terms of progress. There was a 2010 Institute of Medicine workshop where they assessed how far have we come in reducing health disparities, progress since 2000. Health disparities are not going away. Economic hardship is an important contributor. And what does NIH have to do with economic hardship, other than giving us grants so that it eases our economic hardship? Institutional racism and racial discrimination persist. Residential segregation, community environment are important factors. Low levels of awareness among the general public, policies of federal agencies besides those directly related to health need to be altered. Community input initiation is key, and the Affordable Care Act should help. This is now, of course, passed during the Obama administration. And so the Affordable Care Act, and yet you also know that the Congress repeals it every so often. They pass, I don't know, a dozen repeals of the act. They don't go anywhere because the Senate hasn't done it too. But clearly, if the Affordable Care Act is going to be providing the help, there's some vulnerability there. And I come from a state which has decided not to expand Medicaid, and I don't think it's going to cooperate on one of the health exchanges either. So the Department of Health and Human Services had some summits to discuss progress and the way forward. Is a HHS-wide endeavor involving a broad spectrum of the federal government. So now a lot of agencies, not just the ones that are specifically concerned with health research in a narrow way. The agenda will build on the momentum of the 2008 summit, because this is not the first one, and the increased interest of federal agencies to demonstrate their commitment towards improving the health of all Americans. So maybe you've noticed this increase. This is during the Obama administration, and certainly he spoke about these things with eloquence and commitment. The 2012 Disparity Summit represents an ongoing focus on emerging science and its intersection with practice and policy, while maintaining momentum on current national and international trends in addressing the social determinants of health. So the wording evolves a little bit, but the disparities tend not to evolve. So let's take some examples of where epidemiologic evidence does get translated into eliminating disparities, or one where it does and one where it hasn't. So to eliminate a health disparity through public health action, one could think of these 7 steps as being necessary. Attention, advocacy. People have to think this is important. The politicians do, the public will, and so on. There needs to be documentation, so demonstrate that this disparity exists, and prioritization. So of all the various things that need to be done, is this a priority? Need to have interventions identified and evaluated so we actually have things we can do. They need to be scalable, not just having interventions that have been demonstrated in small populations, but it has to be able to be rolled out to the country. It needs to be cost effective. There need to be delivery methods, because implementation science is a serious business. We need to identify the resources, need to acquire them, and you need to maintain them from year to year, budget to budget, administration to administration. And then you need feedback and affirmation that, yes, the disparities are being reduced at least. So the 2 examples I'm going to use are childhood immunization and measles elimination, and then HIV/AIDS. Childhood immunization and measles elimination was pursued with a dual strategy: universal interventions plus targeted interventions. So when this program got started, they used data from 1985 as a baseline. The gap in measles coverage was 15% for, I think this was African Americans versus whites. I can't remember whether it was whites and African Americans or whites and non-whites. Non-whites versus white. So it was 15%, and through this program, it was believed that it reduced to 6% by 1992 and then to 2%. And the risk ratio for disease, for measles, among non-white children versus white declined from a ratio of 4 to 7 to 4 to the elimination of endemic disease. So this is a true triumph of public health and a success in eliminating disparities, and one of the very few that I'm aware of. So here's a graph that shows the measles vaccination coverage, and you can see that there is this fairly significant difference between non-whites and whites. And then in more recent years, 1992, after the initiative had been gotten in place, now we're looking at black rather than non-white and white. And you can see that the 2 lines, they meet, they cross, they're essentially right at the top. So the vaccines are now being received, or at least they were as of 2001. And this parity has been maintained. This was maintained among preschool children in the United States. And this shows several racial ethnic groups. And you can't really find which one is which and differentiate them because they're all so clustered together, at least above 90%. Along with the immunization, measles disappeared. So we had these substantial rates of measles per 100,000. The white one is way down at the bottom, but it's still there. But African Americans, blacks, Hispanics, and Asian Pacific Islanders, Native Americans is substantial. But all of them came down fairly rapidly, and they're down, gone. It's a terrific triumph. What about HIV/AIDS? So in 1983, the CDC began tracking the breakdown of HIV by race. So they first became aware that there was a difference. 1985, Black AIDS organizations were founded, and the first Black AIDS conference was held in 1986. Interestingly, in 1986, the American Public Health Association held its first session on AIDS. This was actually in 2000. No one of color was invited to participate in the American Public Health Association's first session on AIDS in October of 1986. In 2004, I'm jumping ahead, AIDS became the leading cause of death for young black women. The disparity was huge before then, but it had risen above other causes of death. Needle injection drug use was one of the things that was responsible for this large disparity. And as you know, there was a federal ban on needle exchange programs, on use of federal funds for needle exchange programs. And so that was certainly a contributor to maintaining the disparity. And Congress finally removed the ban on federal funding for needle exchange programs in 2010. And then a year later, it reinstated it. In 2012, the Black AIDS Institute report came out highlighting the high HIV rates. For example, blacks have a higher rate of undiagnosed HIV infections compared to other groups, according to it should be February report. Although they make up less than 14% of the U.S. population, blacks make up 44% of all new infections. And this is not something new. This Endgame is the name of a PBS Frontline special on HIV. The PBS Frontline did a 4-hour program called The Age of AIDS, which is a fascinating presentation of the history of HIV and the response around the world. And I highly recommend it, and I actually have assign it to my class. But then they came out with a new installment called Endgame, which is specifically about HIV in blacks, and I highly recommend that one too. So let's analyze the difference between these two health problems. I have them listed by 6 dimensions. So in terms of the magnitude of the problem, HIV one is bigger. In terms of being embedded in socioeconomic dimensions of the society and the socioeconomic context so that it's hard to change the factors that influence HIV without changing more fundamental things. Well, HIV is more embedded. Immunization, you bring people into a clinical setting, or you actually can go to where they are and you give them an injection, you do some tracking, and never mind the rest. Whereas with HIV, you're dealing with people's lives, the constraints on them, how they get their money, who their people they associate with are, whether they're dealing with things that keep them away from getting health care, whether they get adequate health care when they get health care, all the myriad things that affect what happens in a person's life. Availability of interventions. We had effective vaccines. We had ways to deliver them. HIV, well, there's obviously no vaccine. We have highly effective antiretrovirals, and they do reduce infectiousness considerably. So there are, and there's early detection and so on. So there are interventions, but they're not as powerfully effective as immunization. They're not one time, typically, and they're harder to implement. Cost and cost effectiveness. Well, that means low cost, cost effectiveness. Well, immunization, much more cost effective, much less total cost. Using the existing healthcare infrastructure, immunization has an advantage there also. Neutral or favorable to commercial, religious, and political interests. Very few people want to see kids getting measles. And these are both communicable diseases. It's not just a question of, well, I might catch measles, whereas I'm not worried about catching it. I mean, people probably think that, but these are both communicable diseases, and that's one important rationale for public health. But HIV has stimulated some of the most vociferous responses and obstructions from commercial, religious especially, and political interests. As you know, during the Reagan administration, HIV was not discussed at high levels, if not publicly discussed at high levels of the presidential administration for years until Surgeon General Koop, until Reagan was invited to give a talk to the AIDS, American AIDS Foundation, by Elizabeth Taylor, who of course knew him. And so his speechwriter was meeting with the Surgeon General, and the Surgeon General said, this was Surgeon General Koop, Edward Koop, said, I've never spoken with the president about HIV. And he thought, the speechwriter said, this isn't going to look good if he comes to give this speech, and he's never talked to his own Surgeon General. So he arranged for a Surgeon General, a meeting between Koop and Ronald Reagan with a photo op and everything. And Ronald Reagan, and then they were talking points. The speech was written, and it was vetted and transformed and so on. And he went out to give the speech. And midway through the speech, he starts talking about things like, and we're going to screen people coming for a visa, and we're not going to let anybody who's infected come to the United States. And the audience got up and turned around and stood with their backs to him for the rest of the presentation. So this is powerful political stuff that we're talking about. And of course, there's sermons. This is what God does to people who violate laws of nature. So what do you expect? And we have my home state former Senator Jesse Helms banning the use of federal funds for anything related to homosexuality and condom. And I mean, it's very sensitive stuff. And when things are sensitive like that, and it's not only the politicians. They are responding to things that they get from religious leaders and political groups and individuals and so on. And a lot of things in public health are deeply involved with powerful interests in society. And then it's very helpful if you have an immediate impact, a marketable impact. Look at these children. Look, no measles. Look, everybody's vaccinated, wearing little buttons or something like that. With HIV, what do? You put people, hey, my HIV's been detected. I'm no longer unknown. I'm no longer undetected. Oh, I'm on my antiretrovirals now. I mean, yes, there are people who are bold enough to come forward for the marketing programs, but it's not really a typical sort of thing. Not easy to do. This was from that 1985 task force report. So at the time, the task force acknowledged that the factors responsible for the health disparity are complex and defy simplistic solutions. Health status is influenced by the interaction of physiological, cultural, psychological, and societal factors that are poorly understood for the general population and even less so for minorities. So it's not a surprise, it should not be, and it isn't a surprise, that not so much success has developed. You might think, well, we need to be doing research on physiological, cultural, psychological, and societal factors, right? Because that's what's driving the disparity, and we've said this disparity is something that we need to eliminate. Well, in the 1980s, NIH research for funding for social science was cut way back because it was regarded as political. And so the National Institute of Mental Health, their money was essentially targeted completely to biological sources, factors rather than psychosocial. So we kind of took away our ability to deal with these things at the time when it was being recognized that, yeah, we really need to do these things. The other thing is HIV, it is transmitted by injection drug use, which is something that we've had a great deal of problem dealing with effectively. And it's transmitted by sexual intercourse, including particularly by anal sex, which is something that most of us don't like to talk about. When the HIV epidemic hit, we didn't have decent population data on the prevalence of male same-sex behavior, intercourse in the United States. Where did they get their statistics that they started to use? Anybody know? Remember? From the Kinsey report, 1948, sexual behavior in the human male. It's really quite extraordinary when you think about it. 30 years, data 30 years old is what they went back to. And those data were not collected by these modern sample survey methods we have, that we have all these refinements of the design and the sampling and the analysis. They were collected in a very interesting way, which I think Kinsey did heroic work to collect. But nowadays people say we can't use those for national estimates and things like that. We also didn't have comprehensive data on other adult sexuality or on adolescent sexuality. So then in the 90s, there was a national survey of adult sexuality funded by NIH, or attempted to be funded, and then it didn't happen. Eventually, it was funded by foundations privately. The University of Chicago got private money to do it. So there was a national sexuality study in the United States, finally, in the 90s. What about adolescents? Very important population for sexuality. Marie Harvey and Jocelyn are doing all this work with this longitudinal study and everything. So where were those data then? Well, UNC got a grant from the National Institute of Child and Human Development to do a national study on adolescent sexuality. They got the grant. There was a lot of excitement. They were tooling up, hiring staff. And then 6 months later, a California congressman learned of this. And he said, they're going to use federal funds to ask kids whether they're having sex. And they're going to put it in their eye. I mean, this is outrageous. And he made enough of a concern, raised enough of a concern. Of course, he wasn't the only one, but he got the chorus going, that the Secretary of Health and Human Services pulled the grant, an NIH peer-reviewed, awarded grant in writing and all that, 6 months into it. And it was gone. So it makes it very difficult to deal with things when you can't get the data, can't study them. So propositions about human behavior. I see I'm looking at the clock and I'm thinking about, I have a whole hour, but of course it's not a whole hour. So I want to give you a chance to ask questions and make comments. So I'll move through the rest. Propositions about human behavior. History is a record of competition and cooperation. I once got this book. My wife got it to me because I was interested in history. So I pulled out the page for the 1st century BC. And you can't read the text, of course, but you see these little symbols of knives and axes or whatever it is, and they're all over the place. Those are wars. So there's a lot of competition among people and cooperation. A lot of competition, a lot of fighting. This probably speaks for itself. So what's going on? What's going on with human behavior? Well, living systems are made up of fundamental building blocks. Quarks, electrons, go as fine as you can, but they're organized into organelles and cells and organs and so on. And living systems replicate, diversify, compete, cooperate. They invade, they incorporate one another, they combine, and they evolve into systems of increasing complexity. And complex living systems have nervous systems that can create the experiences of consciousness, memory, imagination, deductive logic, extrapolation, anticipation, prediction, and all the other mental functions that we know and love. These mental functions are generated by the interactions of over 100 billion individual agents. Neurons, that is. And then there are in the context of other types of cells and the factors they secrete, as well as other internal and environmental chemico-physical influences. So I learned a number of years ago that I wasn't really a good manager, and I couldn't really manage a staff of even 3. Can anybody manage 100 billion? Who manages 100 billion neurons? I mean, so who's running the show? They are the show, and we're the manifestation. But inside your head, you've got 100 billion neurons stimulating, inhibiting, modulating, and all that sort of stuff. And the result of that is my voice, the commands to my muscles to project. You're hearing things, and your nerves are firing, and so on and so on. And it's all a very, very complicated business. The resulting thoughts and actions, which are also influenced by perceptions and expectations of other thoughts and actions, are generally aimed at advancing the organism's interests, as these are perceived by the organism and responded to by the 100 billion plus agents. So I'm up here trying to make a good impression, trying to convey some ideas. That's what my agenda is. And your agendas, you've got all sorts of different agendas. Some people are thinking, I want to get out of here. Some people are thinking, gee, I didn't get lunch yet. Other people are thinking, this is really fascinating. Other people are thinking, why is he doing it this way? There are all these different agendas and so on. Collaborations, organizations, governments, strategic plans, policies, legislation, enforcement, everything else reflects these myriad competing influences. All these people competing, all these billions of neurons competing. And ultimately, better outcomes require that thoughts and actions reflect more accurate, efficient, coherent, and integrated brain functioning. When you are forming an organization, College of Public Health, you bring in people that you think will be able to do the job. They've got the qualities that are necessary, the abilities, the experience, and so on. And you couldn't function if you didn't do that. How could you have a success? There's searches. Marie is hiring all these faculty, and she's interviewing them and reviewing their experience and everything like that. Because you need people like that to succeed. But who chose people for society? We have a democracy here, that our government, the policy decisions and all that are the will of the people. They're decided by the people. Should we do something about climate change? It's a popular question. And did we select people because they were equipped for this? No, clearly not. A lot of them wouldn't have been, I might not have been selected. But you have them all. You don't get the choice the way Marie does in terms of choosing people to be on the faculty. Epidemiology should assign greater importance to understanding nutritional, microbiological, hormonal, environmental, behavioral, social, and institutional influences on the functioning of the nervous system and behavioral implications. Why epidemiology? Well, I'm an epidemiologist. I teach a course in epidemiology, and I wanted to talk about things like this. There have been pronouncements that epidemiology is transdisciplinary and should be equipped to do this sort of thing. But as I say, when I say epidemiology, I mean population, studying population health, and I don't restrict it to the profession of epidemiology. So challenges for epidemiology and anybody else. So epidemiology has been called the basic science of public health. Can epidemiology really study basic processes and fundamental determinants of public health? We assume we can. Fundamental determinants of health are biological, behavioral, environmental, and health services. But health services reflect human behavior. And increasingly, the environment reflects human behavior. So is human behavior, heavily influenced by biology, the fundamental determinant? So I've got just a couple of studies here to kind of give you some of the flavor of the research that's being done, not by epidemiologists for the most part, or by others doing epidemiology, but I read Science magazine with some consistency, and it's every month or so there's another article on issues like this. So this was a study of the development of the concept of fairness. And they did this by having the children play a game called a variant of what's called the dictator game, where one child gets to decide a reward for the other child, and it's just that decision. And they found that as the children entered adolescence, they increasingly view inequalities as reflecting differences in individual achievements, but not luck, as fair. So children tend to have a high premium on equity, equality. Everybody should have the same result. But as they move into adolescence, they begin to differentiate. They think, well, you know, actually what's fair is that people get rewarded for their accomplishments. And that's, of course, what we're trying to teach them. And I had an interesting discussion with Marie last night about whether salaries should be reflecting people's achievement. I mean, which achievements should they reflect? If you get grants, should you get a higher salary? Or is teaching that important that you should get the same salary, whichever? I mean, these are age-old debates that will continue to go on forever. But it's interesting that the children would be inclined to say everybody should get the same thing. But as you move up, and adults are in that category, efficiency considerations become important also. The dinner that cost Bill Gates, Warren Buffett, and other celebrities billions. So do we know why people donate money as opposed to cause trouble or are selfish? This week, 40 billionaires worth a combined $230 billion signed a giving pledge to donate at least 50% of their wealth to good causes. So that sort of thing could go a long way in reducing disparities, certainly. We could use more of that. Do we have any idea what promotes generosity? There are, I mean, in science, there are articles on smaller scales, of course. And of course, the people who are in the development business are interested in what's on promoting development. I mean, there are people who study human behavior and study how to influence human behavior. And of course, you've probably heard of marketing. And what does marketing do other than try to influence us? For a long time, it was generally assumed that many of the mental processes that make goal pursuit possible require consciousness. But in the past decade, the scientific study of goal pursuit has discovered that these processes can also operate without conscious awareness, and hence human behavior may originate in a kind of unconscious will. There's some fascinating studies that are going on. We think we are in control. We think we're doing things voluntarily. But it turns out that there's at least some indication that quite a bit of what's going on is being influenced beneath our radar, and maybe not even just beneath our radar, but it's just going on. And we're, oh, I guess this is what I want to do, because that's what I'm doing. I start to reach for this, and then I realize I'm going to put my hand out. It's kind of like, you know, if I have to do this, I'm going to want to do it. Here's something else that could give us pause that could be studied, that is being studied epidemiologically. The results of this study show that long working hours may be one of the risk factors that have a negative effect on cognitive performance in middle age. So is cognitive performance in middle age important? Duh. And is overwork possibly reducing it? Could be. Could be. And what are we going to do about that? Are we going to work less hard? Oh, we're going to take more time off and exercise and not drive our subordinates. Well, I want 2 papers, not just 1. I want 3. I want another grant. I mean, how are we going to deal with this? This is fundamental to our whole society. And yet, if we're doing it at the cost of our cognitive abilities, what are the implications? Can we deal with things like climate change without the best cognitive abilities? One example. So you've probably heard of the war in Afghanistan and the war in Iraq. Where did they come from? Decisions made by people who I'm sure were bright, I'm sure were knowledgeable, and I'm sure had terrible judgment. And we will pay for this for the rest of our lives. And not only we, but look what's happening in so many parts of the world now, thanks to those decisions. We can't really afford to have too many more decisions like that. And if our cognitive abilities are not at their peak, and this is just one possibility, right? I haven't talked about computer screens, video games, multitasking, cell phone. I mean, who knows? But is anybody studying these things? Are there much resources? Is this something that we're really working on? You know, when smoking and lung cancer, when that link was demonstrated fairly well, though not conclusively, but there were several studies came out in 1950, most doctors smoked. Most public health people smoked. Men smoked, and they were all mostly men. So this is not easy to deal with. And you could talk about lack of exercise, sedentary living, the whole works. So can consciousness be improved? This is what gives me hope. Transcendental meditation, often called TM, is attracting increasing interest. One reason for that is that the David Lynch Foundation, David Lynch, the filmmaker, has created a foundation to disseminate transcendental meditation. One of the settings in which they do it are schools, like inner city schools particularly, schools in poor communities. They have what's called the Quiet Time program, where all the kids come, when they come to school, they all sit down and they have a period of time that they practice TM. And if they didn't want to practice TM, they didn't want to learn TM, they just have their eyes closed or they sit quietly or whatever it is. And many, many, many students do this, and the teachers can learn, and many of them do. And the schools are transformed from what they were. I mean, you've undoubtedly read and seen the horror stories of what some of our inner city schools are like. It's not only that TM is making the individual students more calm, broader awareness, appreciative, less frustrated, and that sort of thing, but it's making their peers that way too. And so they're not being provoked the way they are in many of these settings. So it's extremely powerful to do it in that way. And the David Lynch Foundation has been doing this not only in schools, but also in prisons, with people in homeless shelters. There's some American Indian tribes that have adopted it. There are international programs. It's all around the world, in schools, in other kinds of places. There are programs for veterans suffering from PTSD, and the military is evaluating it as one possible adjunct treatment for PTSD. There's some very powerful testimonials. If you go to the David Lynch Foundation website, there's some very powerful, moving testimonials. Now, these are testimonials, right? I'm an epidemiologist. I shouldn't be telling you about testimonials. Where is the epidemiology? There is some. There are lots of studies, but they're not the kind of studies that epidemiologists really want to see. Big studies, big resources, well-designed, long-term, all sorts of relevant things measured. Those are very expensive. You know, the HDFP, the Hypertension Detection and Follow program, which was what we had that proved or demonstrated that taking antihypertensives for people with borderline hypertension would improve health outcomes, reduce strokes and heart attacks. It was like about $100 million. This was back in the 70s. So these things are pretty expensive. Who's going to pay that for a study on TM? Can epidemiologists evaluate a holistic intervention with a long-term impact? It's very hard to do. But in some ways, it doesn't matter, because the decisions about what to do, as you've partly seen, are not actually driven primarily by scientific evidence. They're driven by what the people who have influence over the decisions think is best for themselves, their families, their communities, their constituencies, their colleagues, their population, however widely they spread. And it may be very wide. There are people who, I do what I think is best for the world, and then there are people who say, I do what's best for number one. I don't know if you remember when the governor of Florida changed his position from we're not going to expand Medicaid to actually we are going to expand Medicaid. And he said, well, you know, my mother needed Medicaid. And I hadn't realized. Governor hadn't realized that real people could need this and not be able to get health care. But now it affected him. And of course, what happens to everybody affects everybody. It's not always direct. It's usually not direct. It's not always easy to see. It may not even be always that strongly. But when you're driving down the highway, what do you want the people around you to be? Frustrated, angry, upset, depressed, anxious, maybe under the influence. That's what you want, right? Because you want to be the one who's the best, right? I'm in the best shape, I'm the most successful, and all those other people. No, you don't want that. You want calm, educated, relaxed, mentally healthy, alert, etc. people. But we don't think that way most of the time. We think about what we're kind of, our brains have evolved to think about close at hand and close at hand in time and so on. So I think we need to broaden consciousness. And TM is not the only way to do it. It happens to be a systematic, very easy way on which there's a lot of experience. It's not the only way. But if we don't find ways to broaden consciousness, I don't think that public health is going to be able to succeed at its goals. And my time is up. I wanted to give you time for questions, but I will just show you my promotion. This is a prettier version of the flyer I was giving out earlier. We're having a webcast on early childhood development in about 2 weeks. June the 4th, there'll be 3 speakers, including the National Director of Head Start. And it'll be interactive. You can email in questions or Facebook them or Twitter them or whatever your favorite social medium is. You probably have heard that early childhood is a critical time, and that things that happen in early childhood, whether it be abuse or stress or nutritional deficiencies, exposure to toxic substances, they change the body in ways that are enduring, that affect school performance, that affect later, and some may never be reversed, and they affect things like executive function, which affects behavior and so on. So a lot of the things that we're dealing with, a lot of the disadvantages that manifest in underrepresentation begin during preconceptional health. So that's enough of your time I've taken right now. I've got a few more slides I can show you if anybody wants to see them, but thank you very much for listening. You've been a very attentive audience. Thank you very much. Thank you. So, would anybody like to say anything? Yes.
Can you talk more about your current research in transcendental meditation? You said that's your current area. You're working with the David Lynch Foundation?
I send them money every month. That's the extent of my work with them. And I go around promoting them, and I put a little line about them on my personal advertiser. It says, please join me in supporting the David Lynch Foundation. When I learned TM in 1972 in the fall because my brother learned it and told me I should try it, and I thought it would help him to stay with it, and it seemed to be good for him. My girlfriend learned it. We'd met in public health. And we both meditated. We married eventually, thanks to TM, I think. At least partly. Anyway, long story short, I got the idea that I wanted to do research on TM. So I thought, well, I have my master's in health ed, but I need a Ph.D. in epidemiology. So I actually applied to the Department of Epidemiology. Believe it or not, the man who sponsored my getting into the department learned TM to help me coax me into the program. Incredible man. But I never have done research on TM.
Okay, so with those interventions that are being done with that foundation, there's no interest in doing a study of those?
I hope there is. I mean, they do some data collection, But the TM movement has been involved in scientific research, like major publications, NIH and stuff, going back to the 1960s even, I think, or at least the early 1970s. Because when my brother told me about it, he said, and he gave me these reprints of blood pressure going down, heart rate and oxygen consumption and all that during TM, and less stress and improved mental function on some things. So there's an extensive body, hundreds of studies. They're typically fairly small. They're almost all, but not all, but almost all done by people who are real believers in TM. And of course, of course they're going to find, drug companies find that their drugs work, right? And you think, well, they're drug companies, right? There's their drugs. So there's always a certain amount of skepticism about that. And then, of course, there are people who really think this is outrageous, and their studies don't find a benefit. And you say, well, okay. So what we need are dispassionate researchers to get adequate research. Oh, there are a lot of there are a lot of people who aren't invested in either side, to get ample resources to do some of these studies. And I think there's a great opportunity because it's in a lot of schools now, and there are all these tests that students take. Should be possible to get a hold of test data and say, hey, look, these schools, they brought it in. Now, they're not usually randomly assigned because it's hard to do that. But I've been doing this since 1972, and I've seen enough that I'm pretty much convinced that there's something there, that it is really profound. And I've also come to think that you can't know the truth for most important questions. Now, that may seem like heresy coming from an epidemiologist, but in fact, all you can do is see what the studies that have come out say. There can always be another study coming out later, and they say, hey, all those studies back then, they were measuring this thing in this way, but that's wrong. And it's rare, right? But the point is that there are rare things out there that every so often, even in physics, we all thought it was like this. Oh, no. The Big Bang. When the Big Bang came in, why it's called the Big Bang? The idea that there was this giant explosion from almost a space of the whole universe was in this point, and then it all expanded and went out rapidly. It increased. It's an incredible story. And could anybody believe this? And that's why they called it the Big Bang. It's now the leading theory of how the cosmos evolved. So, this is the way people work. Most people will believe in what's been well demonstrated, and a few people on the outliers won't. They'll be like climate change. So most of the scientists think that climate's changing, humans are responsible, we could do something about it, and so on. And then there's a fringe who don't believe that. Some of them are just doing it for money, I suppose, but some may really believe it. And we'll all say, but they're kooks. They shouldn't be whatever it is. And if they go to peer review, we'll all turn down their articles, we won't fund their grants and everything. But, every once in a while in a situation like that, turns out they were right. And so you can't ever be completely sure, or you can be sure. And people say, well, how confident are you? Gee, you can be confident with very different amounts of information. So I don't mean to, one needs to do epidemiology, and one needs to look for evidence, because otherwise you can't operate rationally. But even operating rationally is not enough to give you truth. You can, because there are assumptions in everything. And assumptions, as we've found over the years, so like treasuries, something I don't have to worry about is that the U.S. government will not honor treasury bills, right? There was never any question about that. Ever since the Revolution, when we assumed the debt of the Articles of Confederacy, the treasury bills, that's sacrosanct. And then last year we learned that, they were actually thinking about, So what can you be so forever confident about? And there's a range of people. Evolution requires diversity. So some people are very confident. Some people they don't accept anything. And you need that because over evolutionary time, long time, lots of different environments happening, you've got a species marching forward. And if they all go in one direction, and it turns out that this is the 1 in 10,000th time, the 1 in a millionth time that direction is going to wipe them out. They can't afford to do that. Those species that did that, you don't see them now, right? They're not here because they didn't make it. So a species that has survived and of course it's multiple species because they're descendants of species and so on, must have had enough diversity in it to deal or to circumnavigate, not for individuals to, but for enough of the species to do it to repopulate itself through all sorts of incredibly unusual situations. I mean, there were no weapons of mass destruction in Iraq. But maybe there's one somewhere we didn't find. A tiny probability. Who can say, right? And maybe we'll say, wow, George Bush was right. It turns out there were, or Colin Powell, whatever, there were these weapons, and we just didn't find them before because they hid them so well. And it's a good thing that we invaded. Might be. It's not my position, but, there's no way to be sure. I'm sorry, I'm taking up all your question time. I like to talk. Yes?
I don't know if this question is going to make sense. It's more kind of asking for your advice on how we can understand our role, whether we're epidemiologists or public health professionals. So we exist in this very complicated landscape where our professional identity is based on scientific process, clean processes. All of our work, evidence-based, has to be put all over it. Yet I fully agree with you that what we're able to gather evidence on is a potentially very small sliver of what actually is impacting our world.
Mm-hmm.
So knowledge isn't limited to what we can collect evidence on.
Mm-hmm.
But then again, our professional identity is tied to, we have special knowledge because we've been able to engage in these processes. So that's one, how do we understand our own work within this larger thing and present it to other people? Secondly, oftentimes when we're pursuing this very clean knowledge, we end up, I and many others teach an undergrad class on HIV. I show Endgame. We talk about these other factors. Yes.
Good for you. Good for you.
And when we talk about social determinants of health, though, I still feel limitation because we know that a lot of these social determinants are determined by politics. Yet politics is a very unclean area for us to walk into. Yet you mentioned 7 different examples of how politics actually determines whether that epidemiological data or our work has any impact. So I guess what I'm pointing to are these messy areas. We hang our hat on scientific certainty, our processes, yet it exists in a very messy, loaded territory. How do we navigate that as professionals in public health?
With luck. So how do we navigate as professionals in public health this incredibly complex and challenging way to move forward? And how do we deal with the fact that in epidemiology we can only, or in other sciences, we can only study certain areas well, and that's what we need to study because we have to study them well, but they're not necessarily even the most important ones. And I guess I don't, of course, have a satisfying answer to that. You knew that in advance, I'm sure. First of all, we do what we have to. You could study anything you like with any variables you like and so on, and you could have no job. So you have to study. Most decisions are made by other people. So you'll be reviewed for tenure. Your students will evaluate your classes. Your articles will be reviewed. Your manuscripts will be reviewed by journal reviewers and editors and so on. So you have to do what they want or they won't happen. So you'll have to do clean stuff. And if it's not the most important, you'll have to do what's being funded, whether it is or not. And that's just, it's like we all have to eat. And so we all have to, do this and that, and that's life. But as your awareness broadens, you can maybe find places where you can insert things that will help make a difference. And you can help to change the agenda to some extent, partly by showing to people how it's in their interest to do something different. I think this thing about people doing what they see as in their interest is fundamental. And, in our ordinary daily life, we know that. I put on, like if I wore perfume, I put on perfume so that other people would think better of me. They would be stimulated. You wear clothing that you think looks good because you want people to be favorably impressed. If we were rational people, if this were all intellectual, why would I be up here in a jacket and tie? I could be up here in a bathing suit because it wouldn't matter because, we're just all real rational, right? You're just going to be thinking about the logic. So it's a fiction that we believe. But evidence is what we do to persuade people. You're about persuading people that what you found means something, and the way you do that is presenting evidence. I'm kind of breaking the rules a little bit, because here I'm telling you the TM makes a great deal of difference, is really powerful and so on, and I'm not presenting you with evidence. So that's breaking the rules a little bit. But I'm doing other things to try to persuade you anyway, right? So that's what life is. And I'm not sure if I think the two questions, I kind of merged them a bit. But, one last thing, because I'm sure I'm out of time. Imagine, we've heard of the concept of intelligent design. I don't really know what the details of it are, but the concept is intriguing. So imagine you're there at the dawn of life. Life doesn't exist, but it's your opportunity to create life as a phenomenon, and the objective is to create it to last as long as possible. But you don't get to meddle. You create it, and it's out there, and you can watch. So that's what you do. What would you build? What would you build into this prototype of life that would then go out and flower into all the species and everything like that? Well, you'd build in reproduction, right? Because you don't put all your eggs in one basket. You'd build in the capacity, a mechanism for diversifying, because you can't afford to have everybody go down the one route, so you need diversity. You'd put in a motive to get resources, because nothing happens without resources, and so these things need to be able to get their resources. You'd put in the ability to compete, because, of course, if you have all these things reproducing and going after resources, clearly they're going to be bumping into each other. But you'd also put in the ability to cooperate, right? Because if people cooperate, then they can outcompete the others. Or not just people. Animals, bacteria, doesn't matter what you're talking about. This is existence. This is life. All these things. So you can think this through, and you'll find that a lot of what we see around us, well, of course it's that way. How could it have come through all those millions of years without it? And is that discouraging? Well, when you practice TM, you feel better about these things. Because your mind settles down to experience unbounded awareness. And that's very fulfilling. Thank you very much. Really appreciate it. Thank you.